Um, Today, we're going to have a grand rounds kind of labeled as a symposium. This has been a project that pertinent players on the living donor team have been wanting to put together for, I guess, several months. And we felt that this would probably be the best forum to present it at rather than some type of closed meeting, since this would be a presentation that the entire transplant community of ours should be aware of. So we're going to have a number of presenters up here today who are intimately involved with the living donor team, and to include the HLA lab, our social workers, our physicians, whom I'm missing. Oh, okay, Dr. McGeary. Where is Dr. McGeary? There he is, back there. Okay, well, so I'm going to go ahead and hand it off to Dr. Edwards.
Cover method? All right. Perfect. Thank you. Thank you. All right. Well, good morning, everyone. So I'm glad that we're doing this today. I know that this is something that has been something we've been wanting to do, for quite some time. So just to start off, I think it's always good to have that perspective of what are the needs in terms of when we're talking about donation. And so I just wanted to highlight some of the numbers in terms of our need for kidneys in the United States. More than 500,000 people are on dialysis, and roughly 185 of those have functioning transplants. In terms of the need, you can see that that's quite substantial. When we look at the causes of end-stage renal disease, we know that the majority of those people are going to be having diabetic nephropathy. And unfortunately, end-stage renal disease usually presents itself in the late 4th, 5th, or 6th decade of life, when people are obviously at the tail end of their careers, and often that results in loss of jobs, loss of productivity. So it's a significant loss in terms of a financial aspect to our patients as well as to the economy in general. Since 2000, the number of individuals that are diagnosed with end-stage renal disease has just multiplied. And it's something that has proven to be a significant cost for our Medicare, and something that we're continuing to have challenges with. In terms of transplant, where we're at, and this is data taken from the NKF website, there are around 123,000 people that are waiting for a life-saving organ transplant. And of that, 82% of those are specifically needing a kidney. So we make up the majority of those individuals that are on the wait list. And in 2013, there were 16,896 kidney transplants that took place in the United States. When we look at the breakdown of that, roughly 33% of those were from living donors themselves. But you can see that the supply and the demand is not proportionate, and there were a significant amount of individuals that died waiting. So we know that dialysis is an option, whether that's hemodialysis or peritoneal dialysis, but we really do know that a life-saving organ can make so much of a better difference. So when we look at the benefits of renal transplantation, we know that obviously it's going to help us in terms of correcting some of the metabolic consequences of chronic kidney disease. This is a paper that was published in 1999, which really changed the course in terms of how we look at transplantation and the benefits of it. And they looked at patients from 1991 to 1997 that were on dialysis that actually received a transplantation. And they looked at the relative risk of death and survival with that. You can see that for the first 3 months after a transplant, the actual relative risk of death is usually equivalent to those that are staying on dialysis versus receiving a transplant. And for your pre-transplant coordinators that are in the room, that is why we spend an inordinate amount of time and effort making sure that our patients are going to have a minimal perioperative, postoperative risk. But as you can see, that 3 months after their transplant, the relative risk of death substantially declines to the point where when you're comparing patients that are on dialysis, their annual death rate is around 16.1% per 100 patient years versus transplant recipients, which is 3.8. So looking at that should just get us all excited about transplant. And so we know that with a transplant, they're going to benefit from the freedom of dialysis, being able to return to their jobs and hopefully become productive members of society once again, improved exercise capacity, improved longevity and quality of life, and then for our young females, improved reproductive potential. And then the significant benefit is cost, and we all know that dialysis is a costly affair. Compared to transplant, it's going to save a significant amount of dollars for us for the future. So we know transplant's great, but what is the benefit of a living donor? And you can see here that the longevity of a kidney transplant is enhanced when a living donor comes forward. The procedure is often performed preemptively, so we don't have to subject that individual to a time period of dialysis. We can optimize that recipient as much as possible because it's timed and it's planned. There's very low rates of delayed graft function because of the minimization of cold ischemia time. And really, we're preserving that deceased donor for someone else on that list, especially in light of that significant need that we have. And there are better long-term outcomes, and you can see that graft survival is significantly improved for a living donor. Well, what are the disadvantages? Well, all of the risk lies, unfortunately, with that donor. They do not benefit from this in any regard other than having a warm, fuzzy feeling and feeling that they're really doing something important. And when we're talking to our donors, this is obviously something that we're addressing and assessing. There are 3 major phases of medical risk. The first one is risk of discovery. We put these patients through the gauntlet in terms of their testing, and sometimes we find things that are may not be clinically apparent, but may turn out to be significant in the long run. We put them through the operative risk, and thankfully those risks are low. Perioperative mortality is around 0.03%. I probably have a higher risk of dying crossing the street than I do donating an organ in the form of a nephrectomy, which is good. And the perioperative morbidity in terms of major and minor complications is low as well. Well, what's the long-term risk? We initially have a permanent loss of 30 to 50% of kidney function, and we talk to our patients extensively about that. The long-term risks, unfortunately, are not as well established, and a lot of that is because we can't predict the occurrence of chronic kidney disease in young donors, especially because we know that that usually presents in the 5th or 6th decade of life. So what do? Well, we do an extensive medical evaluation. And I don't think any of us have gone to the doctor and had 16 tubes of blood drawn at one sitting and thought that it was okay. But our donors go through this. One of their first phases of their assessment is laboratory workup. And it's extensive, as you can see here, and I'm not going to go through all of these. For a select number of our donors, we do have them go through specific cardiac clearance, whether that's with an EKG, they all get EKGs, sorry, but stress test or echocardiograms. And then the final usual hurdle that they have to complete in terms of their medical evaluation is the assessment of their renal anatomy. So this is an extensive medical evaluation that we do, and we do it to make sure that we're not going to be having any problems. And once that's been done, then we see them. We have that face-to-face encounter. And you can imagine that this is a donor that's gone through extensive lab testing, has met with our fantastic living donor coordinators, and then they finally have the day where we have this face-to-face interaction. And that's usually the schedule that they have to have. It's a pretty extensive day, but thankfully we're able to pack it in one day. But you can imagine that at the end of it, when I'm seeing them in the afternoon, I'm like, hey, how are you doing? You know, there's some fatigue showing and they're like, this has been a full day, but they're willing to do it, and they're wanting to be able to help their loved one. So I think that overall, and I think the culture of our program has been one where we really are trying to be thorough, and that's important. But I think that our goal should not be, let me do such an extensive search to make sure that I can find a reason why this person cannot donate. And I think that's sort of a change in culture that we're trying to adopt. It's important for us to be safe. It's important for us to be cautious. But our assessment and the things that we do ensure the safety of our donors. And so we're really trying to change that environment. And what we do extensively is inform our patients about what are the long-term risks, because we can't predict what the future will hold for them. There have been 2 very good studies that have looked at long-term outcomes of donors, one in the U.S. and the other in Norway. And combined, they've looked at around 100,000 donors. And the absolute risk of end-stage renal disease was assessed. And we can see that in healthy controls, it's relatively low. In the general population, all comers, it's relatively high, 33 out of 1,000. And in kidney donors, it's 9 out of 1,000. So the risk is not the same as a healthy donor, a healthy individual, but we know that it's a safe risk. And when we looked at those donor characteristics in terms of what prompted them to unfortunately go down that path of becoming end-stage renal disease, they were older in age, African Americans, males more commonly than females. They were smokers. They had gained weight and had developed hypertension. And more often than not, they were biologically related to their recipient. So when we're counseling our patients, we go through this. We go through these numbers. We go through those relative characteristics that will predispose them or have an increased risk of them developing end-stage renal disease. But we know for the most part, as long as we're having long-term follow-up, we can catch some of these things early and hopefully prevent the development of end-stage renal disease. We specifically counsel our ladies who are coming forward, who are at childbearing age, what are their risks in terms of becoming pregnant and having a family down the road. And this is a study that was recently published looking at donors in Canada and their incidence of gestational hypertension and preeclampsia. And you can see, compared to healthy controls, there is a slightly increased incidence of gestational hypertension and preeclampsia. But thankfully, there was no difference in maternal or fetal outcomes. No donor experienced maternal or fetal death. And so most women are able to go through an uncomplicated pregnancy post-donation. So in summary, we recognize the need for more kidney donors. We know that it offers the best outcomes for our patients, and it's a safe process. And the medical evaluation that we do is extensive, and it assures that it's going to be safe. And informed consent is really going to be our safety net and long-term follow-up in terms of making sure that our donors continue to be safe post-donation. So rather than looking at it as a bunch of hurdles that need to be crossed, I think that we really need to embrace the fact that these are people that are coming forth willingly and voluntarily to give of their time and of themselves, and we really need to just roll out the red carpet for them. All right, and I think we got Liz next.
Good morning. This is my first time at Grand Round, so I'm a little bit nervous. And Tricia invited the whole department. Yay, Tricia. So I'm Elizabeth. I've been with the Transplant social work department for about 5.5 years. We have quite a large group of social workers. There's about 5 of us in the department, and we all rotate through all the organs. I'm going to quickly take you through our psychosocial assessment of the live donor, particularly for kidney, but it runs almost in the same vein for livers. When we are asked to evaluate a live donor. Every donor gets a psychosocial evaluation. Those evaluations are done in private. They're confidential evaluations with the social worker and the donor alone. We do sometimes, we will talk with the caregivers as well. If they are present, we bring them in at the tail end of that interview, simply to talk with them about the recovery phase, what's expected of the caregiver, what their loved one is going to go through. But the meat of the assessment is done in private with the social worker. To eliminate any bias in that assessment, we try not to have the same social worker evaluate both the donor and the recipient. And we find that has been very helpful in our practice, that we have two different social workers working the case, one from the live donor side, one from the recipient side, in order to maintain the integrity. In the first part of our psychosocial assessment, we began by talking to the donor regarding the relationship with the recipient. Are they related to the recipient? Are they friends? How close of a friendship is that? That leads us into their motivation for donation. And we also are talking to them and making sure that their donation is free, is of free will, that there is no coercion involved in their donation. Most of our donors that come to us are going to have some type of relationship with their recipient. There's a very small population that we call the altruistic donor. All donors are altruistic. They're all giving of themselves. But this particular population, these are donors who present that have no relationship to the recipient, who simply contact the transplant center and say, I want to donate an organ, whether it be a piece of my liver or it be a kidney. Whoever you choose as the transplant center, I'm okay with that. And whether I meet that individual or not, I'm okay with that too. So that's a small population. We probably do maybe about 1 to 3 altruistic donors a year. We have to, in our evaluation, inform the donors that it is a federal crime for any person to knowingly acquire, obtain, or otherwise transfer any human organ for valuable consideration. So we need to make sure that this donor is fully aware that it is an offense to do that, and that they are truly coming to us from an altruistic perspective. We move on then to evaluate their support system, and within that we talk about their family support, their social support, their emotional support, and their caregiver support. Who is in your network? Specifically, who is in your household? What are the family dynamics in your household, and how does that play into the relationship, if any, with the recipient? And are you comfortable going forward with this donation? Part of our assessment is also pretty technical. We are involved in talking to the donors about risks of donation. We need to make sure that they have informed consent before they make this big decision to actually commit to this surgery. So we talk to them also about their place of employment. Are you employed? Where are you employed? How long have you been there? What are your job requirements with your employer? And primarily we do that because we want to find out, are these donors do they have realistic return to work expectations? If you're going to donate an organ and you're a construction worker or you're an oil field worker and you're working out in the hot sun, is it realistic to think you're going to go back to work in 10 days? If you're a bank teller, if you're a social worker, is it realistic to think you need to be out for 6 months? So we need to come to an agreement on what those expectations are. And sometimes, though, it's a few conversations between the donor and the social worker, and then the social worker and the team, and then the physician and the donor, to come to an agreement to what we all feel is comfortable for this donor. If you don't work, you don't get paid. And so we talk to them about their resources that they have, if they have any. Some of our donors come to us and they're very well prepared. They've talked to their HR departments. They have their paperwork. They know what they're going to do. They have a plan. They've been saving, and that's great. Some of our donors come to us and they're in the initial stages of coming to this decision. So they don't have the tools. They don't even know the questions to ask. So part of our evaluation is the education of the donor, to talk to them about programs like FMLA, how to use their personal vacation time, short-term disability, donated pool, or federal paid leave for those federal employees. If a donor is in the military, then special case for those donors, because sometimes those donors are required to go back to their commanders, go back to their posts, and they must have a military physical to return to work. So we need to make sure that there's a plan for them. We need to identify, if you're out of work, do you have a plan? And if you don't have one at the time of evaluation, like Dr. Edwards says, that's not a barrier. It's simply just a highlight to say, we need to have a plan. Let me help you make a plan. Let's see if we can get there together. We, in going forward in that vein, of course, everyone's always concerned about insurance and how is this paid for and who's going to take care of me while I'm in the hospital, who's going to pay for all this testing that is going on. Well, for the donors, everything is covered under the recipient's insurance. So the coverage depends upon the recipient. So those who... and especially with big payers like Medicare, we pretty have that much down to a pretty good science. But when recipients and donor pairs come to us and that recipient has an employer group health plan, so the recipient is employed or their spouse is employed and they have an employer group health plan, that's a little bit different. And so examples of that would be, for example, with Aetna. Aetna only allows donors right now to be a spouse or a blood relative, to include a sibling, children, or parents. So if a recipient presents with that type of insurance, it's a little bit more complicated for financial to get that authorization to proceed to go on. Humana accepts all donors, living related or unrelated. So for some people, it can make a difference whether or not they can get a living donor simply because of the recipient's insurance. And that carries you through the evaluation and the surgery, but then we worry about the post-care. And what about the post-care for these donors? We've already established we're going to put them at a higher risk. They're losing this one kidney. Who's going to care for them in the immediate post-op care? Who's going to care for them for the rest of their life should they have any donor-related complications? For donors who have Medicare recipients, all donor-related complications are covered for the life of the donor, even if the recipient is deceased. So that's the most comprehensive type of coverage you're going to have. If your recipient has Medicare, you're going to have post-donor coverage for donor-related complications for the rest of your life. Employer group health plans, a little bit more tricky. They don't offer that type of extended coverage. They usually offer time-limited coverage, and that's dependent on the plan. For some, it's 30 days. For some, it's 60. For some, it's 6 months, a year. It just depends. And if your recipient loses their insurance, or the insurance changes, or they die, then a lot of times, well, in all cases, really, that coverage is gone for the post-donor. So those don't carry over. So if your recipient had Humana this calendar year and the employer group changes to Aetna next year, well, you were transplanted under Humana. So your donor coverage, if you had any left, terminates with that. So these are conversations that we're having with these donors when they're coming in to let them know what their risks are as far as going forward, and really, do they need to be insured under their own policies? Everybody, in my opinion, I think needs to be insured. You just never know. If your recipient has Medicaid, there is no coverage for post-donor care. So you come in, you have your surgery, you're evaluated, you have your surgery, and you're done. Medicaid stops. So there's no post-donor care for those donors. You might also wonder what other type of donor expenses do they incur? We're asking somebody to take time off of work. That's going to cause a drop in income for the household. Are they incurring any other out-of-pocket expenses? And the answer is most likely going to be yes. Long-term expenses, well, it's medical. You know, are they going to need to continue to have their own health insurance coverage, depending on whether or not they get coverage from the recipient? And at the time of surgery and at the time of eval, if they're out-of-town donors, they're incurring travel and lodging expenses. So they've got to travel to the transplant center. They've got to have this evaluation, which lasts about 1 to 3 days. Then they have to come back for the surgery, which lasts about, the hospitalization, about 3 to 4 days. And then they need to come back for a surgical follow-up 1 week post-discharge. So all that time, if you have a non-local donor, all that time, all that expense, all that money needs to be spent. And so who's going to spend it? How's it going to get paid for? There's a few financial assistance programs for donors. There's the National Living Donor Assistance Fund. There's the American Transplant Fund. And there's some transplant center-based funds that we're very lucky to have. And then for some individuals, they're able to do private fundraising and allow their donors to access those funds. The most popular form of assistance is NLDAC, which is National Living Donor Assistance Center Foundation, and it's a little tricky. Their financial eligibility is based on a donor-recipient matrix, which is weighted heavily on the recipient's income, not the donors. So your recipient must be financially challenged. And what NLDAC will do, if you are approved, is they will provide travel and lodging assistance for one donor and two caregivers. No, one donor and one caregiver for 2 trips. One donor, 2 caregivers for 1 trip. So there is some planning involved with these donors even before they come to the transplant center to say, we can offer you this assistance. If you qualify or you have been qualified, you need to make a decision. Is it one donor and one caregiver for 2 trips, or is it one donor and 2 caregivers for 1 trip? Grants are distributed in the form of an American Express debit card. Local donors only eligible for gas money and a very small food budget. And if the donor has incurred expenses already leading up to this transplant before they're approved, they cannot be reimbursed. So for donors who want to be very proactive and say, well, I'm going to buy my ticket because it'll be cheaper if I buy it in October because I need to go in December, you will not be reimbursed for that. So you must wait. Well, what if you don't tell me till 2 weeks before? My ticket's going to be $1,200. Well, your ticket will be $1,200, and NLDAC will fund that. But if you want that travel and lodging assistance, you cannot pay out of pocket. They will not reimburse you. There is a small cash disbursement that NLDAC allows to cover expenses that cannot be paid for electronically. Very small amount of cash that you can withdraw. This is an example of a LDAP budget. In this case, it's an evaluation trip and a surgery trip. And you can see they're pretty generous budgets. For the evaluation trip, the total budget is $1,627. And for the surgery trip, the budget was $4,220. If a donor runs short in one category, they can move money from one part of their budget to another part of their budget. If you didn't spend that much in airfare and you want to move that down to food, or you want to move it down to get a rental car, you can do that by calling NLDAC. They're very, very flexible with the budget. American Transplant Fund is a different type of resource that donors have to access. Those grants are capped at $1,000. Those grants can only be dispersed after the donation has occurred. So we need to call them and tell them, yes, it actually happened. Please release the money. These grants can be applied to household expenses, is what we usually use them for, such as mortgage payments, rent payments, electricity, car payments. We are prohibited from asking for loss of pay compensation. So if you're going to be out of work for 2 weeks, we can't pay your 2 weeks salary, but I can pay your mortgage if it's $1,000 or less. Neither of these programs you can combine together, so you need to pick which program you want to apply for. And then for some of our population, they actually can do quite well with fundraising, and fundraising can be initiated by either the recipient, the donor, or by the community at large, different organizations, your places of employment. Also online resources. We're now in the digital age, social media, so resources such as GoFundMe have become very popular with transplant patients, and they can rack up a sizable amount in their fundraising accounts. Moving on from finances, the next part of our evaluation deals with mental health. Mental health is extremely important to the donor team. We want to make sure that our donors, like I said before, have informed consent. They're doing this of their own free will. Their motivation is clear, and they're able to make good decisions. For all altruistic donors, a referral to the transplant psychiatry department is mandatory. So if you are coming to us and you say, I don't know anybody here, but I want to donate my organ, we're going to send you to the psychiatry department. Just to cover all bases. All other referrals are at the discretion of the social worker and the medical team. So if we feel in assessment that we need that resource, we will definitely refer. We go over past history regarding if you have any mental health diagnoses, what your treatment plans are. Do you have any community resources already in place, like counselors or treating psychiatrists? We evaluate for current symptoms of depression and anxiety. We talk to patients about post-traumatic stress disorder in detail. We talk to them about past traumas and significant deaths, unresolved grief issues that they may be carrying around with them that can impact their care, especially if they're under a lot of stress, and transplant can be stressful. We talk with them also about substance abuse, past history, current use, and if there are any issues there, a discussion with the multidisciplinary team ensues to discuss if there are any contraindications to transplant, if anyone has concerns that this donor may have an episode of relapse in the future. And then we talk to them about the risks of living donation. I think every member of the team talks to the donor about risks, the short-term and the long-term risks. Short-term risks to include transplant failure, pain during recovery, the financial risk that your household may incur if you have to take time away from work. We talk to them also about what I call the spotlight effect. Everyone is showering attention on these donors, the donor team, the recipient. Even afterwards, everyone is so grateful and thankful, and they are the apple of everybody's eye, and they should be. They did a great thing. Well, 3 to 4 months down the road, time moves on. And a lot of times, if you have had some other motive spurring you through this evaluation, you may feel very deflated. You may feel very depressed. You may become anxious. And those might manifest themselves in your relationships that you have with your family, with your coworkers. And so we monitor that. You know, we want to know if these donors are encountering these problems going forward. And then the long-term risks of donation to include the ability to apply for health care. We don't know what the future holds with health care. Currently, right now, I won't go into that, but everybody should be able to apply for health care. But in the future, we don't know. And we don't know what future health complications you are going to have. We can try our best to predict, but we really can't give you a guarantee with a gold seal on it. And we talk to them in depth and at length about their relationship with the recipient, and if there's any opportunity, if they have any inkling that they may not be able to maintain with that relationship with the recipient, or changes in the relationship with the recipient. You know, we've all gone through that. You know, we have friends we're very close to maybe in college, and we don't see them now but on Facebook, or our best friend moves away and they're states away, and we don't talk to them very much anymore, and this could significantly impact the donor going forward, thinking I've done this for this person, you know, and now maybe they're not going to be here for me when I need them. So we talk to that with our recipients. The entire interview lasts about an hour and a half, and that's the first interview. If we have issues, questions, or concerns, then we may bring them back for a second interview. We may call them on the phone leading up to evaluation to see how they're doing. We want all of our donors to be comfortable with the level of risk that is involved. And next is Dr. McGeary.
All right, so I'm Don McGeary. I'm one of the scary mental health providers that we send people to. And so what I want to do is talk to you a little bit about what happens and some of the reasons and goals that we have for doing a psychiatric or psychological risk assessment with the donors that come through. And just to give you a sense of what our goals are and a little bit of my background, I've been working with the transplant team here in consultation for about the past year, but spent 7 years with the U.S. Air Force during that time. I was pretty deeply involved with bone marrow transplant for a long while, in a similar role, and also doing a little more work on the back end of social support groups, stress management groups for donors and recipients alike. So diving into this, there are a couple of goals for coming and seeing someone like me. And obviously the first one is that I need to make sure that they can handle the donation and that they know what they're getting into and have a very clear idea. But the second is probably more important, which is to make them not afraid of me. And a lot of people overlook that. It's really important, I think, in a process like this when you are dealing particularly with a population of individuals who might not have had a lot of interaction with mental health before. Some have, but most of them have not. And you want to make sure that when they come through, one, that they're not afraid. And I unfortunately do get comments from people who come in and see me saying things along the lines of, wow, you were a lot more normal than I thought you would be. And this wasn't quite what I thought it would be. And yes, very much so. Please feel free to let your donors know that I am not going to ask them to lay down on a couch and talk about their mom or their potty training or anything like that. This is really a lot more laid back and a little more straightforward. So I want them to feel comfortable with me. And one of the big reasons for that is because, as we know, it is a stressful process, which means there might be problems that will pop up on the back end after they donate or after they receive. And I want them to be comfortable coming back to me if they need me. That's really important. And what we found is that there actually is a strain of research data available in the extant literature to show that if a person has a good experience with a mental health provider on the front end, that they are more likely to utilize services later. And that's really important for the third point that I have there, is that we may have some people who come in for a screening and they're not looking good when we first screen them. And as I'm sure a lot of you know, and as we've already detailed this morning, the screening process in and of itself for a donor is actually very, very comprehensive and very expensive. And what that means is that if we can recover people who might not be a great candidate right away, that's really good for us. And so from a psychiatric perspective, if we can identify risk factors in a person that might make them somewhat of a risk now for donation, that doesn't mean that they're not suitable. All that means is they might need a little bit of work before they become suitable. So my goal is not only to identify risk, but to contemplate whether or not that can be recovered and we can save resources that way. So again, the goal is to make sure that they're not afraid of me and that they will actually come back so that we can work on that. The models that you're looking for would be straight cognitive and behavioral therapy models. There are a number of different ways of doing these things, and supplement that with medication as much as you can, but there's decent evidence to suggest that a lot of these risk factors can be identified and easily managed with a CBT intervention. So what do we know so far? It is a sad state of the research literature for psychosocial risk factors for transplant donation and reception, actually. Unfortunately, although there have been studies that have been published, not a lot is known. That's why some of the references that you see up there are somewhat dated. One thing we know right away, though, is that risk for adverse outcomes, at least adverse psychosocial outcomes, so we're talking about things like increases in rates of depression, anxiety, maladjustment, PTSD, or suicide. They're actually quite low. I mean, we're talking on order of around 4%, maybe less, which is about the average population. So it is a stressful process, but it's good to know that most people actually can handle it pretty well. And I spend a lot of my time working. I split my time doing a lot of work in post-traumatic stress with military personnel who experience very traumatic circumstances. What you find is even though we hear a lot about PTSD in the news and the popular media, the rates of PTSD are actually lower than you would think. That people you have a large portion of individuals who face fairly traumatic circumstances come out just fine on the other side. So it's reasonable to expect that. We know that having a good psych team, if there are risks, can mitigate that. I cited myself. My experience has shown this to be true. Unfortunately, if you try to find research to examine this, there really haven't been any systematic studies of a rehabilitation model for a person who's an otherwise bad candidate. However, my personal experience has shown that that actually is possible. I've had several experiences with individuals who came in expressing risk factors, who have shown risk factors in assessment, was able to prop them up. And you prop them up on the front end and the back end. I treat them before, and then I create a safety net of care afterwards so they can get their way through it and do well. So yeah, I'm comfortable citing myself for that. And then we want to make it count. We want to make sure that those who aren't suitable at the beginning might restore suitability later. If you look at the known risk factors for difficulty, and I apologize for the micrographia here, I'll tick through just a few of these. Some of the known risk factors that are in some of the scant available research, it makes a lot of sense, and it has a lot to do with history and support. When you talk to a mental health provider, especially psychologists, one thing to know about psychologists is there are two things that we really love. Talking is one of them, and testing is the other. And when you work with a psychologist, they're likely to throw every test in the book. And a lot of times when they're doing that, so they're giving MMPIs, MCMIs, and some might do Rorschachs, heaven forbid, the ink blot test. They'll do a lot of these, and a lot of the reasons why is they're fishing for things. But if you ask the question, what are we really looking for here? Well, I'm looking for changes. I'm looking for risks in future behavior. Does anyone know what the best predictor of future behavior is? Past behavior. So really a decent structured clinical interview is going to get most of what you need. For me personally, I use the Stanford Interdisciplinary Psychosocial Assessment for Transplant, the CPAT, and that is a multidimensional, I'll show you some of those dimensions in a minute, multidimensional structured clinical interview that's designed to identify past risk factors that actually might pop up again in the future. But we know that past behavioral problems, so past problems with substance use, past problems with psychiatric conditions, depression, anxiety, past suicide risk, those things will impart future risk, and those are the ones that you really want to identify. And then when you look at the comprehensive model, there are all kinds of things that you want to assess and you want to integrate when you're examining a patient and trying to assess their suitability from a psychosocial perspective. So of course, the mental health history is really important. And I'll often ask my patients, okay, you've worked with a psychiatrist in the past. What kind of intervention was used? Was it medication? Were you adherent? What happened to the symptoms afterwards? If they received more of a psychological intervention, so CBT intervention, self-management of psychological conditions, then I'll ask, are you still using these things? Are they still effective? How is that going? I'm trying to get a sense of their trajectory over time. Substance use, substance abuse, and substance misuse is also really important. So it's not just have you been abusing illicit substances, have you been using illicit substances, have you ever taken pain medications for reasons other than pain? What we know is that when a person starts to misuse their medications that way, that actually does suggest a risk in substance use later. So you want to start to assess some of those things. Just their knowledge of the process. One of the first things I'll tell them when they come in is, I'm the big scary psychologist, but what I really want to know is, do you know what you're getting into? That's really important. And do you understand? And even though this is rehashing a lot of what they've been going through during the day, it's really good to check their understanding. Why are you here? What is expected of you? Do you really think that you can handle that and then substantiate that for me? But I want to make sure they know what they're doing. I also want to assess their motivation, and this has already been covered. Is it altruistic? Why are you doing this? How long-lasting is that going to be? Is there a risk for disappointment later? I also want to make sure that they have readiness for change and that they're expressing that. You need to change your lifestyle after a kidney donation. You have to watch your health. Are you ready for that? Have you ever done that before? Have you ever been on a diet before? How did that go? How long did it last? Why didn't it last very long? Those kinds of questions. And then overall coping. This is actually probably one of the most important things, is that when we're assessing them, hey, when you feel stressed out, like, what do you do about it? And then the more important question, does that work? I punch a wall. Well, does that help? No. So just getting a comprehensive sense of a person this way actually goes a long way towards helping us identify risk factors, understand the risk factors in the context of their ability to manage those right now, but then also to create an environment. And the way I am now is the way I always am, and it drives my wife nuts just less than half the time. But I want to make sure that my patients know that it doesn't have to be some kind of dowdy thing. I want them to be comfortable coming and talking with me. I want them to be comfortable working with me, and I am always happy to talk. I do it for a living, so there's my contact information up there. Thank you very much.
Wow, tough act to follow. Hi, I'm Julie from 4HLA, and thank you for inviting us to share our little piece in the puzzle of the ever-expanding living donor program. Much like you, we've been having our own growing pains, and every day we're looking for ways to improve. And our HLA goal is to provide you the most accurate and up-to-date testing possible so that you can make the best decisions and achieve a good outcome for your patients and donors. Sorry. I think one of the better decisions that we made was to establish a regularly scheduled meeting with Cheryl and her transplant team. This has been a huge eye-opening experience for us, and I wanted to share some of the successful outcomes that have come from this. The first thing was a simple little ABO testing. In the past, what happened was the kits would come in for these potential donors, and then we would send out the ABO testing and then sit and wait, because we didn't know, is this going to be an ABO-compatible donor or not? Sometimes it would take 4 or 5 hours before we got the ABO answer. So this was delaying our testing. These cells are dying as we speak, and everybody was getting really frustrated because we'd be calling the transplant team, come down here, take care of things. And after collaboration, talking about it, it was a very simple answer. Why don't we just do the ABO testing in the pre-part of the evaluation? When they come in for that first 16 tubes that Angelina talked about, throw one more tube on there and get the ABO. Well, that helped us because right away when the tubes come in, we can get our testing done. And also when it was done way back at the beginning, you guys could make the decision, was this donor suitable or not? Because if they were ABO incompatible, then you could right away start to ask them, do you still want to do this? Do you want to go into the paired donor exchange? You could make all those decisions. So that was a really wonderful thing for us and helped. The second thing that I think has been important for us is to establish a schedule. Previously, what would happen to us is we'd walk in, we'd have our schedule in our HLA lab set up because we do antibody testing, we do typings, we do cross matches, we do deceased donor testing, etc. So we had our little schedule. We'd walk in, and then the 10 o'clock FedEx would come, and there would be 3, 4, 5 potential donors in these boxes. And it's like, oh my goodness, because our policy was that we could only have one technologist do one cross-match, Okay, now what are we going to do? We still had all that other stuff we were going to do, and here they show up. So what the scheduling has helped us do is Cheryl and her team, we have one that's on the share drive, I believe it is, or the HLA drive, and so they come in and they know that they're allowed to do 2 cross matches a day. So they schedule those. So we're aware of it, and that enables us to continue on with the other testing that we need to do. So that was a very good process improvement. And then along with that came the idea that we would start to ramp up our testing, because it was not reasonable for us to just do 1 cross match per tech. So we have been gradually getting up. I believe Charles did 3 cross matches the other day, and he's one of our baby techs. So we're getting there. So we're going to help you with that. And another thing that Kenny has put into place is that we are working towards, we have our cross match procedure is a little bit cumbersome, so we're we're narrowing it down. Instead of doing all our T cells in one tube and all our B cells in one tube, we're moving to where everything's done in one tube. So that will increase the turnaround time for you guys as well. So that's another thing that's in there. One of the other problems that we addressed was the recipient sample. Bear in mind, okay, these potential donor blood is showing up in the lab, and we're scrambling trying to figure out how we're going to do the testing at all, and then we look and we don't have a current sample. So tick, 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 the cells are dying. So what we did for that was we've put in place that the donor team and the recipient team are speaking with one another and with HLA. We're all trying to determine, do we have a current recipient in-house before we order the donor blood. So that has been a huge improvement, I think, as well. Every once in a while we have a stumbling block because things get mixed up, but I think that's successful. Another thing that we looked at were the virtual cross matches. We implemented that for if everybody recalls, we had a huge drive where we had 60 plus potential donors that came through. And so we were trying to figure out how could we do this quickly, efficiently, accurately, and get the best outcome from that. And so what we did was we established the virtual cross match. And right away we could take a look at it, predict, was this going to be positive? How did we do that? We look at the patient's HLA type versus the donor's type. We look at the patient's antibody status. I have an antibody to an A2. This donor has an antibody, an A2 antigen. Do I want to take a look at the MFI? Is it like flamingly high, like 30,000 MFI, then maybe that's not a good choice for us. That's going to be positive. Or are they hovering down below our threshold? And can the donor team do their magic and overcome that? So we took a look at all those donors, and very quickly we were able to do the virtual instead of the 6-hour-long physical cross match. Weed out the ones that we knew right away we couldn't, sent them in your magic way off to paired donation maybe, or maybe they're just going to be altruistic donors, that kind of thing. So we got it down and we found the right person, I believe, for that. So now we have the virtual cross match in our repertoire, and I think that's going to keep growing. And the last thing that I think that we worked on is our turnaround time. That was a big issue for everyone in this room. We made that our 2015 QA assessment monitor. Laura has very diligently looked at the first quarter. We've spotted where we need to improve things, and I believe by the second quarter you're going to see an awesome improvement in that. So we look forward to continuing to grow and work with you guys, and we're working on our reporting process. Everybody has a different spin on what they want to see, what they need from us, and just talk to us. We'll get it to you. Thank you.
Well, as you can see, this is truly a multifaceted process to have a living donor evaluated and move towards transplantation. So now let's take a look at where we've been and where we're going. Think back to 1986 and think about what were you doing at that time. Well, here we had our first living donor kidney transplant in January of '86. And since then, we've had almost 400 successful living donor kidney transplants. The year 2014 was an exciting year. We were moving from the 80s now to 2014. In 2014, they had an inaugural Transplant Angel Awards, and our own Carmen Nolan won the award. So this was a truly making history moment for UTC. And what makes this truly special is that the actual living donors and kidney recipients are the ones who are able to nominate personnel from across the country, nurses, physicians, surgeons, and out of all of these nominees, Carmen was the winner. So we really want to continue to acknowledge her and congratulate her. And then at the end of 2014 in December, there was a remarkable media campaign. As you know, Matt's Wish campaign. And in the first month alone, there were hundreds of, actually over 2,000 site visits in the first 2 weeks on the website. And amongst all of those visits to the website, 84 people came forward and completed the comprehensive screenings online. And this was not only a success story for Matt, because in March he was able to find a compatible living donor, but this spread the word about living donation across the nation. And not only for our transplant program, but for other kidney recipients across the nation, just increasing awareness about living donation. We have a number of programmatic goals, and that's part of the reason why we're here, is to share with you guys our goals for the year and our goals for moving forward. And I asked Greg a couple days ago, what's your goal for the living donor program? And he said, it's quite simple. We want to increase the number of living donor transplants. And in doing so, since last year, we've worked on expanding our core team. It's just remarkable that Carmen and Janie together have formulated the core team, and so much of the early program success, over half beyond that of the success, was with one nurse coordinator and one dedicated PCC. And so as we're looking towards our goal of expanding and expansion, we really had to increase our woman power. And as you can see here, Louisa joined us toward the end, August of 2014. Claudia Grimmer were able to share her role with promoting the Living Liver Donor Program and the Living Kidney Donor Program. Linda has joined us, and she's been phenomenal in helping us with our post-donor follow-up. And Janie retired very recently. She's been a part of our core team since onset. So our core living donor team has expanded tremendously. We also, as a second goal, we're working on expediting the donor evaluation process. And so part of that is increasing our team. And then also we're looking at using technology. We're really looking at other ways to try to help increase access for information online, and also to allow the donors from the comfort of their own home, from their couch, to go to the website, learn a little bit about living donor process. And we're actually going to be working with a program called Breeze Transplant, which will allow the donors to click on a link. And as you can see on this example at the Leahy Clinic, they have a click for living kidney donors and a link for living liver donors. And they can answer a series of demographic questions, health history questions, medication review, and there's an algorithm that you can customize per your transplant center's protocol, and they'll either be excluded if they have a significant contraindication like diabetes, for example, but if they have no exclusionary criteria, they are able to complete the entire comprehensive assessment online. This is quite time-saving for the transplant program, and it also allows the donor to have immediate feedback. If they're able to complete the whole comprehensive assessment and there aren't any contraindications, they get this immediate feedback stating that they could be appropriate and that they will be contacted within a certain amount of time by the living donor team. So this really increases their access to immediate feedback for the donors. Another move that we have been working towards since 2014 is to have a one-day donor evaluation. This is our goal. Now, of course, some donors are going to require more than 1 day, but our objective is to try to consolidate as best as we can by having pre-visit testing and laboratory studies and having all of the information available so they can have a one-day visit. And that's the comprehensive visit that Dr. Edwards reviewed. They have a nurse coordinator, and they have education time, additional education time. They meet with a nephrologist, the independent donor advocate, the social worker, dietitian, and if needed, a mental health specialist. The third goal of our program is to expand the kidney pair donation efforts, and we're really working very closely and intimately with our HLA partners to try to help expand options for patients. We're once again looking at technology as well. There's an exciting program. There's a computer software called Biologics TX, and members of the HLA team and the living donor team, we met with the Biologics TX team, and essentially it's a software program. It takes an incredible amount of time to sit down with pen and paper to try to come up with compatible pairs. And essentially what happens is we have a donor who's been identified and a recipient who's been identified, and either they're ABO incompatible or the recipient is highly sensitized and they have a number of antibodies and they're not compatible immunologically with their donor. and so they can't perform a direct donation event. And so we literally have a registry of such patients with a recipient that's ready and a donor that's ready, but they cannot directly donate. We compile this registry of donor-recipient pairs, and you can input their data into this software program, and with the click of a button, it will come up with different potential kidney pair donation chains. This is a software that's been available since 2011, and transplant programs across the country are acquiring it. In March of 2015, at Central Pacific Medical Center in California, they performed a large swap, actually the largest kidney pair donation swap in the state of California, where they had 6 incompatible living kidney and recipient pairs. And this is the largest swap in one center in California. And they were able to have 12 patients, 5 surgeons, and 6 successful transplants in over 2 days. So this happened within one center. I truly believe that this software will allow us to enhance our internal efforts, and the broader scheme is to try to partner with other programs such as UT Houston, UT Southwestern, Christus, because we tend to trust the surgeons at Christus. So I think that we'll be able to work with them as well and really change the pathway for these patients. Our 4th goal is to enhance the long-term follow-up. As you've seen from our multiple presenters, there are challenges that our living donors meet post-donation, and so our goal is to try to enhance that. Jennifer has been working on developing a contract with Walgreens so that at multiple sites across the nation, there's an ability to have some screening available. We are interested in looking at screening such as blood pressure, weight, and even some point-of-care testing to help screen donors pre- and post-donation. And this could try to help some of the needs. We're calling patients, and some of them don't have primary care physicians, and so we can get some preliminary information with our Walgreens partners. We're extremely excited about this partnership. And then our goal ultimately is to have a dedicated post-donor clinic. That's what they truly deserve, to have an avenue, a setting that's reserved just for them, because just like Dr. Edwards says, they truly deserve the red carpet treatment. Right now, the donors are blended in with our recipient clinics, and so it's just, as you can imagine, kind of a chaotic clinic with recipients and all sorts of other organ recipients. We need to have a reserved time and space for them for their follow-up care, and so that's our goal for down the line. So in conclusion, the goal of today is to really let you know that this program would not be successful without the participation and the commitment of every individual in this room. We truly need to have us to continue to work together to meet these goals, and together we can do it. So thank you very much for coming, and please, I welcome your questions. So this is a panel discussion. Everyone's welcome to answer questions and answers.